This episode of Beyond the Tube, Real Stories, Real Advice is proudly brought to you by TubiFun. TubiFun are a fantastic company who endeavour to make tube feeding a little bit more fun for our Tubi kids and their families. Check out TubiFun on Instagram via the link in our show notes. Thanks again to TubiFun for sponsoring today's episode and for your continued support of the Tubi community. Welcome back to Beyond the Tube. Today we are so lucky to be joined by the wonderful Eliza from Milk Munch. Eliza is a speech pathologist who specialises in paediatric feeding, and I know she's got some wonderful insights that are truly going to help all of our viewers and listeners. Welcome, Eliza.
Thanks for having me.
Thank you for coming on. Really appreciate it.
Yeah, no problem.
What is a speech pathologist who specialises in feeding therapy?
Yeah, so having a special clinical interest in the area essentially just means that I've done extra training. I've gone off and done lots of professional development and really looked into that area of paediatric swallowing, paediatric feeding in all different areas. So it's not something that is as well known as a speech pathologist who might do communication therapy, but really important, especially with this cohort of children that we're looking at who might have lots of different feeding challenges.
Yes. So that's, I guess, leads to my next question around the differences between a speech pathologist who is dealing with speech issues versus a speech pathologist who is dealing with feeding issues. There's obviously naturally obvious differences between the two, but for anyone out there who doesn't understand, why would I need both? What are the differences, and why would some children need to have both involved in their care?
Yeah, of course. So I guess at a base level, we've all received the same basic level of training. We all receive training in the area of pediatrics and adults, communication difficulties and swallowing difficulties. But I guess we're looking at children who present with two different, completely different presentations, right? We might have children who have feeding challenges but not have communication challenges. Most often they go together. As a general rule, there's no reason we can't do both. I think what's happening at the moment is we're seeing clinicians move into areas of special clinical interest, which helps them to delve deeper into those two different areas. So it's lovely that we can do both, but to get the best for your child, I would always advocate for separating. We can't do both in a session. There's certainly crossover. You know, we all communicate, so we all have to make sure that we're communicating in a way that supports that child. So feeding therapy will always have a communication element. Communication therapy might not always have a feeding element. I find it really important to separate the two, just to give the best care, basically. So finding a therapist that can do feeding and finding a therapist that can do communication will mean that you get the most out of your therapy.
How do parents advocate for both therapists?
It's a challenging one. And I think it just comes down to the fact that there are two separate issues at hand. Yes, there might be connection, there might be crossover, but again, we can't do both of them in a 1 hour session. We can barely do feeding in a 1 hour session, and you know, communication might be a 30-minute, 45, 60, dependent on the child, right? But kids need to be kids. Kids need to have time where they're just kids, and we can't bombard them with 2 hour sessions just to target these goals. We need to be able to find a way to integrate that into their life, and that might look like having two different therapists, maybe working week on, week off kind of thing. Whatever is clinically indicated for that child.
So what is the difference between oral aversion and dysphagia? And then how do you manage either or both? And can you have both?
Absolutely, you can have both. So an oral aversion is essentially that completely averse or not interested in anything coming towards the face. And it can be as simple as that, really, like no touch, no nothing coming towards the face. And that usually stems from experiences, you know, something negative, something traumatic may have happened coming towards the face or to do with the mouth. And we then see an oral aversion develop. And that is just complete refusal of anything coming towards the mouth. We can see that in newborns, and we can see that in children who might have had an adverse situation, maybe a choking episode, maybe repeated placement of a tube. And it is essentially just that refusal of anything towards the mouth. Dysphagia is a difficulty swallowing in its most basic level. So something to do with the anatomy or physiology of a swallow that means that swallow is not safe. How do we manage them? And can you have both? Absolutely, you can have both. We often find that children who have dysphagia have had such negative experiences with eating and drinking that they develop this oral aversion. Why would you want anything to come towards your mouth that's going to cause you pain when that's happened so many times over and over? How we manage them, I guess it's really comes down to finding out the why behind both of them. So an oral aversion especially, we really want to know what's happened and why might that be there. And we're going to go really slow with an oral aversion, really child-led. And that sometimes can be at the very base level, something like touch to the mouth, touch to the cheeks, touch to the hands. You know, we're getting so far away from the mouth, but we need a child to feel comfortable, safe, have trust that we're not going to do anything to harm them. So an oral aversion is essentially about building back that trust. As for a dysphagia, that's probably more looking at what is the issue behind it and how can we either rehab that or provide support to make that swallow safe. So that might be changing the flow rate, changing the thickness, changing the foods or the fluids that child consumes to actually look at keeping it safe.
And obviously on the back of that, there are studies that can be done to check swallow, make sure that there isn't anything else going on beyond the swallow.
Absolutely.
Completed.
Yeah. So there are what we would call our objective measures. So something like a video fluoroscopic swallow study or a FEES, they are things that provide an objective measure so we can actually look at what's happening.
Yes.
But what we need to remember is that they are still a snapshot. If that child swallows once or twice, that's all we see and then they refuse. So it's something that we use as gold standard and we really rely on using these things to objectively look at what's going on and to also then refer on to other health professionals. So referrals on to ear, nose and throat specialists for scopes, really looking at what is exactly happening with that swallow to go alongside our more bedside measures, I guess. So things like watching, looking at the whole picture, listening to parents with what's going on at home. All of it needs to be combined to help us figure out what's going on.
Absolutely.
And sometimes we don't know what's going on.
That's also true. Definitely a lived experience for me with Ezra. We still don't know what's going on. But what I can say and what I would encourage others is that between our ENT and our therapist, they have great communication. So, and also our pediatrician. So we've got really good communication between the three of those people. And I think the benefit is finding the right specialist. I know for us, our specialist is amazing. I trust him implicitly, but I also trust that he takes recommendation from our feeding therapist seriously.
Yeah.
He doesn't dismiss her recommendations. He doesn't, I suppose doctors and particularly surgeons have an appearance that sometimes can be dismissive and look down upon allied health support because they see themselves to be more important. I don't know whether that's the case with everybody, but it's certainly been a case with a lot of specialists I've worked with. Not my ENT, he's great, but that I think is so important, is particularly when you're talking about snapshots and moments in time, taking these tests, doing these tests, the practical things that we do don't always lead to a diagnosis. They don't always lead to resolution. What would you say to parents who are going through that? You know, they may be in the thick of this and they are not finding resolution. They're just sort of going through the motions and they're feeling a bit maybe deflated and lost. Maybe they don't have a feeding therapist.
Yeah, it's really hard. I think the top thing that comes to mind is advocate and find one person, find one health professional who will help you advocate. Because when you get someone passionate who is really interested in this area, they will advocate and they will advocate hard. So if you can find one person that will hear you, that will listen to you, that's the biggest tip I've got really. I think when we're looking at assessment and diagnosis, that's where it does get really challenging. And you're right, we don't always have an answer and we can't always find an answer. And as much as we'd love to find an answer, it's just not always going to be there. And to a point, it doesn't always change what we're going to do. You know, sometimes it's going to change drastically, the approach that we take. But other times, we're still going to be child-led. We're still going to follow that child's needs, look at their swallow safety, look at what they're doing, what the family needs at that time. And that's going to be what our therapy focuses around. I think in terms of the therapy side of things, if we're talking about not feeling like you're making progress, kind of stalling, we're talking long game here. And I was talking to my sister about this just the other day, and we were just talking about responsive feeding practices in general in children who don't have any other challenges going on, you know, introducing chocolates and lollies and how we're doing that and how we're not demonizing those things. And she was kind of at this point where she said, they still obsess over them. And I said to her, we're playing a long game. We're talking adulthood. We're not talking childhood, really. We're not talking teenagers. We're talking adulthood, that you can be sure that that child is going into life with a safe and healthy relationship with food. And that's the long game. And I thought that was super important to put in here because we are talking long game.
Yep.
Not much happens with feeding therapy overnight. It is long term. And it's so important because we all have food is the center of so much of what we do that it's so important to think about that long game.
Absolutely.
And know that we're going to take it one step forward and two steps back sometimes. And that's unfortunately the way it goes. Kids develop and kids make changes overnight, and that sometimes means that they step back in so many other developmental areas, and that's just what we kind of have to keep going with and keep working with.
It's important as a parent, and yes, I appreciate it's hard to do when you've got lots of other things, moving parts, other appointments, things happening around you or around your child. It's important to step back and look at how far you've come.
We often say to parents, take a video today, and when you're feeling deflated, when you feel like there's been no progress, go back and look at that video, because you might not see huge feeding change, but you're going to see huge developmental change. And what a nice thing to look at, right? What a nice thing to go, wow, look at where we were 3 months ago. All of the tiny little nuances of a child, they change so regularly. If you can take video, take more video than photo, because it really brings it back home for you about how much you've done, how much you've gone through, what change you've made, and look at that little person in front of you. Aren't they amazing?
I agree. And we would do these things with our babies when they start solids. We do this already. There doesn't have to be a difference. It can be the same type of experience. Obviously, there's, maybe some trauma or some other elements going on in the background. But when you bring it home, they're learning to eat. They're learning to trust their airways. They're learning to trust their swallow. They're learning to, desensitize. Whatever the case may be, or maybe all of those things, that's all happening. That's all very real for them. And I think it's particularly hard when you've had other children that haven't had those issues, because you compare. You don't mean to compare, but you do compare. Yeah. So you're going back and you're looking at, well, this was the feeding experience for my previous child, at the same age.
Why is it not going the same way?
Exactly.
Yeah.
Exactly. And I think that's, to your point, videos are fabulous resources to have, because yes, their journey might be different, but it's their journey to take.
Yeah.
It's not a comparison between two kids. They're running a very different race.
Yeah, absolutely.
So when it comes to tube feeding, and you've got a child or a client who is tube fed, and let's say in this instance they have an NG tube, which for those out there that may not know, an NG tube is inserted through the nose and goes down the esophagus into the stomach, and is generally taped to the face, and then has the feeding port at the end of the tube, which is normally affixed to the back of the child's clothing or some sort of, cute little pouch or something that keeps it out of the way. When you enter into a session with a child who has a tube feed, what do you do?
I think it is really dependent on where the child's at, what level they're at with their oral feeds. That might look like slowly introducing tastes, textures, keeping it safe for them, maybe slowly weaning off thickened fluids, depending on what their swallow safety looks like. It is really child-led. When we're talking about children who are fully fed via a tube, they don't have very many oral experiences at all. We're talking about introducing foods through touch and feel, appearance, that kind of thing. So we're really starting at any step that child is comfortable at. It's really important that we're very child-led, we're very responsive. We are so in tune with how they communicate their wants and needs, and really looking for those subtle signs of distress in any way. And that's where we kind of pull back and know that's our stopping point, and that's where we're going to focus on improving the next time once we build some trust, once that child feels safe and happy. In terms of whether it's a nasogastric tube or a G tube or anything else, I guess the experience in the session is not overly different, because I'm not playing with that tube. I'm not touching that tube. That is not part of my role.
Yep.
My role is to make sure that child is safe with what they're consuming through their mouth, and making sure that they are in an environment that is comfortable, that they can trust, that they are happy in, to be able to build those experiences for them.
Which I think is a really good point. Really important point to highlight in big, bold capital letters is that building trust around anything that is entering the mouth is hugely important. In my experience, and obviously I can only speak of my own with Ezra, is that in order to build that trust with that person who is encouraging them to do something that does not feel natural, that does not feel normal, and that does not feel safe, is really important. So there is no association in my experience between the tube, in whatever form it is, and the therapy session, because they are, for that time frame, separate entities. And I think that really fosters the safe environment, that trust, because you're right, you're not touching it. You're not having anything to do with it. They can trust that you're only here to help me put some stuff near my mouth or play with some things today, or whatever the case may be, wherever that child's up to in their journey of feeding.
Yeah.
I think that's really important to highlight, because children have fear. Tube-fed children have real fear around people coming near their face, because in most experiences, most children, I don't know what the percentage would be, but I imagine it's quite high, they start with an NG tube. It may only be for a short period.
Yeah.
In Ezra's experience, it was 16 months of an NG tube.
Yeah.
So anytime someone was coming towards him, expecting him to do something with his mouth, his automatic, even at 1.5, expectation was, you're going to give me a new tube. You're going to touch my tube.
Yep.
So that trust element is incredibly important.
Absolutely. And I always say connection over consumption. That's what we're all about, is being responsive, connecting with that child, and making sure that they are safe and happy, because how are we going to eat if we're not safe and happy? I mean, there's a physiological response that happens when a child or when a person is anxious. If anyone's ever experienced anxiety, you generally experience a suppression of your appetite. Your body doesn't want to eat. It's going into fight or flight. It's protecting. So when I present food to a child who is highly anxious because the environment that they are in is expecting them to be something that they can't quite be yet, they're not going to be interested in that food at all. We're going to take our 2 steps back because we've gone too hard, too fast. We need to stop. We need to connect. We need to make sure that they're safe. And then we need to start slowly introducing things at a level that is appropriate for that child to make them feel safe.
Absolutely. I agree. And as I sit here talking to you, I'm literally picturing Ezra at our dining room table doing all of these things.
And I mean, that goes for children who are hesitant eaters for whatever reason. Even in a normal developmental stage of that fussy eater, they still come to the dinner table thinking, hold on a minute, that's new, never seen that before. we have this reaction that happens where the body goes, nah, we have to go into protect mode. You know, that's what we were created to do, is to protect ourselves. So that stands for any child who has any sort of feeding challenges. Is just protection mode first. So let's go connection, let's go fun, let's make it happy, let's make it safe. That's what us as adults enjoy about our meal times, right? Like we don't
Absolutely
go out to a cafe to feel anxious and not eat anything. We go out there to enjoy it.
Definitely. And I think that it's not that hard to implement it. You know, the things that you learn in therapy sessions are really easy things to implement at home. You know, that suggestion of just trying to implement something new. It might be once a week. You put something new on that plate. Something safe, but something new that gives them the opportunity to investigate it. It may just be playing with it. It could just be throwing it on the floor. Could just be feeling it. Maybe it's touching to the lip. Maybe it's licking it. You know, whatever it is, whatever that looks like for your child, it's incredibly important that they've learnt those skills through their feeding therapy sessions to be able to slowly move forward. And it is, like you said, it's a marathon, not a sprint.
Absolutely. It's a long term.
It's for someone like me who likes instant gratification and I want to see results today. I don't want to wait. It's really difficult. It's been a very humbling experience for me to have a child who doesn't eat traditionally or eats very minimally, depending on the day and what has happened leading up to. It definitely has been something that I've had to get comfortable in, you know, and we talk about uncomfortable situations, and could there be anything more uncomfortable for a child than sitting on a table where they feel out of place, they don't feel like they belong?
Absolutely.
You know, I've started to have these conversations with Ezra, given that he's 3.5 now.
Yeah.
He can articulate a lot better. His vocabulary is slowly expanding.
Yeah.
And he will tell us now that, you know, he doesn't want to sit at the table. I'm not going to push that.
Yeah.
Because I want his association with sitting at the table to be positive.
Absolutely.
Some days he does just want an Aldi chocolate for dinner.
Yeah.
And that's what he'll get.
I just want to go back to your point of introducing different therapy ideas at home, and, you know, that it doesn't have to be really complex or really hard. And I think that's something that I really enjoy about this role, is finding the simplicity in the complexity. You know, we've got these children who do have tube feeds, who on the outside look incredibly complex and have medical backgrounds and assessments galore behind them. But really, at a base level, some simple things is all you need to make some really nice change. And having fun is one of the most simple things that we can do, right? I think something we do in our house is we make smoothies every so often. And something that's really fun about making the smoothies is that we always pick something green to go in the smoothie. And it doesn't matter what that green thing is. That could be green sprinkles. It could be a squirt of some green icing. It could be some spinach. But that is something fun that we as a family do just to make it enjoyable, but also to show that food is food, and something green doesn't have to be scary. It can be really fun. It can be a jelly snake that gets blitzed up in that Thermomix to make a really nice smoothie. Like, it can be anything. But isn't it fun to put something in there that you wouldn't expect normally?
Yes.
And it creates such a joyous occasion for my toddler to run around trying to find something green that can go in the smoothie and loves it, you know? So it's about being fun. It's about finding that simplicity, and, you know, that's taking the pressure off.
Offline, we discussed the need for more speech pathologists who have this special interest in feeding therapy, which I completely agree with. I mean, we're very fortunate that we already work with you and your team, so we're super lucky. But not everybody is, and I'm thinking about our friends in regional areas, and I'm thinking about our friends who may be in other countries where perhaps this is not something that is used. I'm not sure what it looks like worldwide. Obviously, we can only talk about what's happening here in New South Wales and here in Australia. But why, if I was training to become a speech pathologist, or I may already be one, it could be a speech pathologist listening today, why did you choose to have this special interest in feeding therapy, and why should somebody else consider it?
For me, it comes down to that complexity. My brain thrives on trying to figure out these complexities. But like I said before, then coming back and looking at it big picture and thinking, what are some simple changes that we can make that will make this family's life easier? For me, I also have this, food is the center of so much of what we do. And I love to cook. I love to host. I love to have meals with people. And I kind of come back to this idea of, well, shouldn't everyone have that? Shouldn't everyone get to do that? So I love the anatomy. I love the physiology. I love figuring out what is going on with that child's swallow and pulling it all together. It's almost like this slight medical side of things without having to go really deep down in that medical route, essentially.
Yeah.
I think for others, you have to have a love of supporting families with this mealtime environment. And I know a lot of therapists might have had their own challenges with feeding, and that's where they kind of pull it together and go, well, this is what I've done and this is how it's helped me and this is where I want to go next. But you also do need to be you need to be a detective and you need to advocate and you need to have this strong interest in finding a solution for some families to make things a little bit more enjoyable, a little bit more simple at mealtimes.
Again, I picture my own situation here and I just think tick, tick, tick. This is kind of what I'm doing in my head because I do think that you've got to have the right temperament and I definitely think patience. I mean, Ezra is a very active toddler. I imagine there's lots of kids that are in the same boat, but I also imagine there's a flip side of that where there are children who maybe can't articulate at all. There may be no nonverbal, and there may be other kids who have physical barriers to their eat meals that still have these problems. So I think you would definitely need a lot of patience.
Absolutely. I think any speech pathologist needs a lot of patience, especially in the pediatric world. Like we can have a lot of fun, but we also do need to be calm and patient and support that family and also recognize that what we see is 45 minutes to an hour of what is a parent's life. So we get to be patient in that hour, but we also fully understand that that's not how it goes at home sometimes because you can't really. And when you have children of your own, you really, really get a good insight into that as well.
Definitely. Yeah. Definitely.
But patience is definitely, I would say, something that we should study at uni. Because we all seem to have it, that we've gone into this profession for a reason. And we all seem to have this patience for these children because we do. That's what we want to do. We want to help them out. And you can't help someone out unless you have compassion and I guess a little bit of patience as well.
In a feeding therapy session, what does success look like and how would you describe that to somebody?
Yeah, so I guess that is so individual and this is what we really want families to know is that progress can be so small and success is what you deem it to be, really. So something that we really like to do is make sure that we're on the same playing field. I'm not coming to a session thinking tomorrow we're eating. I'm coming to a session thinking, like we said before, long term, that really long game is what we're playing. So I think a family needs to be on the same page. And if we're not, that's where we have troubles. That's where we kind of have these expectations that aren't matching that child. And that's a really important thing to think about as well. We can present these goals, parents can present these goals, but a child doesn't necessarily have the same goals. So we kind of need to make sure that we are following the child's lead in all ways, being really responsive to their needs, whilst guiding them in the right way. It doesn't mean that the child has every say. We still need to provide them with ways to be successful and ways to make change, but we're going to watch them. We're going to watch their subtle cues. So success or progress might look like my mum let me say the word capsicum today and didn't get upset that she said capsicum while standing in the kitchen. Or it could look like taking a bite and taking a bite every night. It's so, there is such a spectrum of what success looks like in feeding therapy that we really need to hone in and tune into all of those really subtle cues. And I think what's really important is letting that child make those decisions. And we do that with every area of development, right? Like it is so much more beneficial when a child has self-motivation to make a change. And we're all sitting there cheering and thinking, don't make a big deal, act cool. Like, they didn't do anything. Let's just keep moving on. And we do that with so many other areas of development as well. So, let's do it at mealtimes. Let's be cool. Let's see it, acknowledge it, move on, kind of thing. Mark it away in our brain. Think about it as a success, but don't expect it tomorrow. Yep. Don't expect it to keep happening. Tick it off. My child has made that choice to do something different. Isn't that amazing? We can move on and keep living our life. And maybe it'll happen. Maybe it won't. Again, but either way, they made a really cool choice that time.
Yeah.
And they made it because they wanted to.
Yes.
Yeah.
What would you say around still on like progress when people are obviously starting in this journey? We may give them, lots of soft and dissolvable food, yogurts and dissolvable type of, I want to say baby foods, but like toddler foods, to sort of get them started and things like that, safe foods. How important when we're going through this and we're looking at progress and moving forward and success is nutrition when it comes to this? Is it important, or is it a case of let them have whatever they want?
No, I think nutrition is really important because our whole body needs to thrive in some way. And that's why we work so closely with our dietitian friends. We need them to be able to support us to make sure a child is meeting their nutritional needs so that their brain is working really well, their body is working really well. They are bright, they are alert, they are willing to participate in all of these big new things. Think about it in the way of, like learning a new gross motor skill. You're going to send a child to a soccer game and they're going to have the best time and they're going to come home. They're going to be starving because they used all of these nutrients to do this new activity. So we need to make sure that we have them fed, we have their nutrient needs being met so that they can then do this new thing and they can provide their whole brain, their whole body into this new experience.
Yeah.
So super important. In terms of, I guess there's the other flip side of that in that when we're working towards new textures, new tastes, new sensory experiences, there is a component of let them eat what they want to eat, because if their nutrient needs are being met through the tube and we're working on mouth feeding and making sure that they're feeling safe and comfortable and they are safe, then sometimes we do just have to have foods for learning.
Yes.
Something I love to talk to parents who are starting solids about is foods for nutrients and foods for learning. So we have to have a balance of both. For any mealtime, we do the same. Like, chocolate gives you some nutrients, but it probably doesn't give me the best nutrients, right? And then my broccoli gives me my nutrients. And, every food has something different in it and we need to experience all of it.
Yeah, I love that. So my key takeaway from that is it is okay to have chocolate for dinner, but only sometimes.
Look, we still get some nice chewing that happens. There's some lovely skills and swallowing. Your body feels pretty good after it. Like, but your body's not going to feel good after it every single night, right? So, we just have to have a balance. Balance is the key to everything.
That's kid life.
Yeah.
Balance.
Yeah.
We could talk on so many topics with balance. Balance is definitely one of those things. I cannot thank you enough for your incredible insight into the world of pediatric feeding therapy and your lived experiences with so many clients, Ezra included in that. We would be, I don't know where we'd be without you guys. I really don't. So, wholeheartedly from me, thank you.
Thanks for having me.
And thanks for all the work you do.
No worries.
It's seen. I see it. And I hope everybody out there sees it as well. But yes, if people haven't already, I think that they need to connect. If they've got a child who does have some sort of oral aversion or there is dysphagia in there, or there may not be a diagnosis yet, they should be connecting with a speech pathologist who does have that special interest in pediatric feeding therapy.
Absolutely. And I think asking the question, what kind of experience do you have? How far does it stem? Because it's important that we are competent and confident in what we're doing.
And for those of us who are on the NDIS or people who are starting that journey, you can definitely get this covered through your NDIS plan alongside a traditional speech therapist who is just focusing on the vocabulary side of things. They can work together. You can get funding for both. So please know that. I stand here as somebody who has both for Ezra's plan. So it's definitely something to take away, because we've discussed that there are people out there who aren't getting funding for both, but it's definitely possible.
Absolutely.
Again, we thank Eliza for joining us today. And until the next time, thanks for coming along on this ride. Stay safe, and we'll see you soon. A big thank you once again to To Be Fun for their sponsorship of today's episode. Please head over to their Instagram page and check out their wonderful products. Alternatively, you can jump onto their website. Their link is in our show notes. Without the sponsorship of companies like To Be Fun, this podcast isn't possible. So thank you again, To Be Fun.